Hello, good morning. Myself Vikas Jaiswal from Endeavor Health, and with me it is great honor to have Professor Maciej Banach, a cardiologist and a lipidologist from Poland. Hello, sir.
Hello, thank you very much for the invitation.
So today we had a trial discuss the role of Olezarsen in patient with atherosclerosis. Can you tell me briefly about it?
Yeah, it was an amazing trial because it was the largest trial so far to measure the role of the reduction of the triglyceride-rich lipoproteins on the atheroma plaque reduction. So with Olezarsen here, antisense oligonucleotide therapy against ApoC3. So we were able, based on the Essence trial, which was published recently, to see whether significant reduction of triglycerides is maybe associated with reduction of the atheroma plaque volume and other parts of the atheroma plaque morphology, take into account the non-calcified atheroma plaque, and to see whether it can be translated into cardiovascular outcomes in the future, taking into account ongoing trials with Olezarsen. So if you look at the population, we see within this trial, we had patients with moderate hypertriglyceridemia, so with the baseline level of triglycerides 249. But if you can see, it is critically important if we look at the final results that those patients were treated very well with lipid-lowering therapy, because most of those patients, 97% of those patients, were on statin therapy. They were patients about, as far as I remember, 20 to 30% on ezetimibe, as well as 20% with icosapentaethyl and fibrates. So if we look at the lipid biomarkers at the very beginning, LDL cholesterol was about 80 milligrams per deciliter. So those patients were indeed very well treated. And if we look at the patients' population, in fact, it was not the same population as we had for those patients which when we tested the role of hypercholesterolemic drugs in patients with on atheroma plaque volume, for example, with PCSK9 inhibitors, ezetimibe, or statins, because they were patients with elevated, obviously, risk, but not so high risk and very high risk in comparison to the Pacmanami, Huygens, and many other different previous trials. So what we were able to see, we've noticed obviously significant reduction of triglycerides, which was expected, right? And even 82% of those patients were on the level of triglycerides after the treatment below 150. We've noticed also significant reduction on non-HDL and many other different parameters, ApoC3 and other lipid parameters. We also noticed 16%, which was quite an important outcome in this trial, of ApoB, and an insignificant reduction by 2%, as far as I remember, of LDL cholesterol. And now it is a critical point because we wanted to see whether 12 months of treatment with Olezarsen as a part of the Essence trial translated into reduction of the atheroma plaque volume, especially non-calcified atheroma plaque volume. And we've noticed that it was no significant reduction of non-calcified atheroma plaque volume, as well as low attenuation plaque, because it was another key secondary outcome we measured. And so the issue is that, okay, what does it mean? Because it is critically important questions, take into account the results of this trial. First of all, it does not mean that reduction of triglyceride-rich lipoproteins does not work, taking into account the outcomes we expect, because we need, for example, to wait for the cardiovascular outcome trial with Olezarsen that is ongoing. Second issue is that we need to think whether these patients were not treated too good, because if we look at the lipid-lowering therapy and the baseline parameters of the lipid profile, I strongly believe that maybe we should have patients on the higher risk, taking into account the baseline lipid profile. Please notice that only 9% of those patients were with severe hypertriglyceridemia over 500. So maybe in this population, we should look whether this might be translated into reduction of the atheroma plaque volume. Another issue is to see whether indeed CCTA analysis is the best one, because in the previous trials we had IVUS, right? We have NIRS and many other different methods, and probably the most important question is whether we should consider longer trials, because if you look at the previous trials with triglycerides reduction, with fenofibrate, with bezafibrate, with others. For example, Accordion trial, Accord OLED trial, and many others. We've noticed, despite the fact that the main outcomes were negative in the end, we've noticed that the longer observation and longer duration of treatment against triglycerides might be associated with a significant reduction of the cardiovascular outcomes. So maybe here also, we also should consider, for example, 24-month, not only 12 months treatment with Olezarsen to see the changes in the atheroma plaque volume. Obviously, it is a kind of hypothesis, but I'm very sure that we first of all focus on the patient's population, which was very well treated, and the question is whether it was enough place for the triglyceride for Olezarsen to still reduce residual cardiovascular disease risk. On the other hand, we need to see whether the longer treatment with Olezarsen might translate into and might cause and result into significant changes in the atheroma plaque volume. In my opinion, these are the most important conclusions. But on the other hand, we can say, based on this data, that 12 months treatment with Olezarsen with significant reduction of triglycerides is not associated with the significant reduction of atheroma plaque volume. The other issue is, please notice, as a kind of also explanation of this, if you look at the placebo arm, right? Usually, if we look at the placebo arm, within the year, there is an increase by 10 to 15% of atheroma plaque volume, right? Here, it was no change, no significant change, and the change was, as far as I remember, 3%. It means, in my opinion, that those people were indeed very well treated, and this is probably one of the reasons that those results were negative, but in my opinion, they are highly interesting, and I'm very much looking forward to see the cardiovascular outcomes data for Olezarsen. I'm very sure, as it was discussed during this late breaking session, that these final results will be positive. I'm very sure of it.
How we can see it can impact our clinical practice in future?
Obviously, I strongly believe that still triglycerides or triglyceride-rich lipoproteins are a significant biomarker to reduce residual cardiovascular disease risk. Obviously, we do not have important agents with good cardiovascular outcomes trial to say that, okay, for patients with this residual cardiovascular risk factor, we have a number of different drugs we may use. One thing we should always consider, please remember that for most of our patients, it is a secondary hypertriglyceridemia, and that is why we should always consider lifestyle changes. This is a very important point if we start treating of those patients with moderate, at least moderate hypertriglyceridemia. Second issue is, obviously, we have a significant, very good data for icosapent ethyl, so that is why it is another arm for us, another drug we might consider for those patients. So I strongly believe that waiting for the cardiovascular outcomes trial for Olezarsen, but also for other drugs that are ongoing, like plozasiran, like pegozafermin, and many others, I strongly believe that we should use this in order to significantly reduce triglycerides. On the other hand, there is also a kind of discussion, especially in those patients with obesity, diabetes, with atherogenic dyslipidemia, that using of GLP-1 receptor agonists might also help us in order to have those patients on target or to significantly reduce triglycerides in this population.
Thank you.
Thank you so much for the invitation.